from antiretroviral drugs, they don't want any investigation into any other possibilities, despite all a mountain of evidence. One way in which they have rather forced the debate is by funding generously organisations which support their point of view. If any organisation has got a highly paid executive and they're receiving huge amounts of money from a pharmaceutical company, most would be pretty stupid to bite the hand that feeds them, because they find in the next year, all of a sudden, that funding's disappeared.
So the money pours in from various organizations in the United States, Western Europe, and the UN, all in the name of finding a cure for AIDS. The people are desperate for treatment, and they trust the doctors who provide them with medications. Sadly, these people are often used as human guinea pigs for new products that generally do not work, and in many cases may actually make the person worse or even kill them. As long as assistance arrives in the form of pills to treat the symptoms, instead of infrastructure changes that can provide clean water, proper medications for malaria, tuberculosis, schistosomiasis, healthier diets, and an end to political conflict and gross poverty, the death toll will continue to rise. Little wonder the public is fearful of HIV testing. A positive HIV antibody test means that a person will eventually develop AIDS, considered by most to be a death sentence. We're also told that early detection and treatment can prolong your life, and that the HIV antibody test is the most accurate method of detection. However, the scientific literature that comes with the test kit clearly states that the test should not be used to diagnose someone as having the HIV virus. Well, if the test kit's own manufacturer states it should not be used for diagnostic procedures, what then is the value of this test?
There are two tests in common use. One's called the ELISA, the other's called the Western blot. The only difference between them is that in the ELISA test, all the so-called HIV proteins, about 10 of them, are all mixed up together in a solution. And in the Western blot, prior to reacting, the proteins have been separated out into a nitrocellulose strip. Now, the test that really matters in all this is the Western blot. So we really don't need to discuss the ELISA test. It's used as a screening test, and it is admitted by experts that it is not sufficiently specific to diagnose HIV infection, whereas the Western blot, if positive, is considered synonymous with HIV infection.
The standard screening test is an ELISA. Occasionally you get a false positive. Under those circumstances, a Western blot can absolutely confirm. Western blots are also important when you have people, for example, who have been vaccinated in vaccine trials and making antibody against one protein. The only way you're going to tell if they're infected serologically is by looking at a Western blot showing they make antibodies to the other protein. So it has a lot of value. It's fundamentally a confirmatory diagnostic test.
It is nearly impossible to determine the rate of false positives because there is no gold standard to independently verify test results.
Depending on the dilution of the blood sample, basically we are all seropositive. It all depends on the dilution of the sample.
At the moment, there is not a gold standard to know if we have antibodies for the presence or absence of antibodies against HIV-1 or HIV-2 in human blood.
There's also data from a number of hospitals in the US, which was published in 1988, where they tested nearly 90,000 blood samples anonymously. These patients were selected to have no risks for HIV infection or AIDS. In some of the hospitals, they found 25% of men were HIV positive on the Western blot, the most specific test, and they found that 8% of women were HIV positive on the Western blot. I mean, this should lead one to question again, how do that many people who have no risk for HIV or AIDS get to have that many HIV antibodies?
If you imagine that this was a breathalyzer and this was an antibody test. Now, breathalyzers are carefully calibrated by comparing them to alcohol. No HIV test, if you look at the literature that comes with them, has ever been calibrated by comparing it to HIV infection. In fact, the instructions actually say that they presume that the presence of antibodies implies presence of the virus. HIV tests have got a well-documented huge list of over 60 things in medical literature, established medical literature, which shows that these tests are completely non-specific. Now, if breathalyzers were validated on that basis, you'd have people convicted of drink driving with a test which has never been compared properly to alcohol, and which it's known that tea, coffee, fruit juice, cola and milk can produce false positives. You'd never be able to convict anybody of drink driving on that basis, but that's the basis on which people are given a diagnosis of a biological death sentence every day.
The arguments that Peter Duesberg originally made, that antibody is normally a sign of immunity, normally is correct. Antibodies are normally a sign of immunity. And it's highly paradoxical that a virus whose levels in the blood are brought down to undetectable levels following the appearance of antibodies can somehow later on go and kill someone 10 years later. It's a real medical conundrum, and the scientific community has not been responsible in addressing this paradox.
One of the best ways to change from positive to negative is simply to change your residence to a different country. This was published in Continuum magazine from London. It was made up by Val Turner, a scientist in Australia who has done a lot of work on HIV antibody tests. There are different criteria for reading these tests, and each one of these columns shows the different criteria from different countries or places. In Africa, all you need is 2 of these bands to be positive. In Australia, you need 4. In the United States, we have 5 different sets of criteria for reading Western blots, and they are all totally different. So if you go to a lab that uses the American Red Cross criteria, you may be positive. And if you go to a lab that uses the FDA criteria, you may be negative. And if you go to a lab that uses the CDC criteria, you will more likely be positive there because they use much more lax criteria.
I don't think that there's anything wrong with different countries having different criteria, because the different criteria are only really for that small group of patients that come in the indeterminate level. When a Western blot is really positive, it hits you like a truck. It's only for that little indeterminate group that you have to be concerned.
In theory, at least, that if you were tested in New York today, then flew to Australia, and you had 3 bands in New York, you would not be positive in Australia, but you would be positive in New York City. Now, I mean, a virus cannot behave in this manner, and this is what has led us to hypothesise that there is no proof that any person with a positive antibody test, no matter how defined, is in fact infected with this so-called lethal retrovirus.
Everybody uses it experimentally, and most people use it clinically around the world. Not, maybe Britain doesn't use it, maybe there are 2 countries that found a better way, God bless them.
When he came up with his first test, he tested 30% of the American blood donators, so let's say the general population, he tested them positive. And the industry said, no, go home, Gallo. We won't buy your test because this is going to destroy our business. And the only thing what he did, he lowered the sensitivity of the antibody test.
If they didn't allow them to charge so much for it, I think there'll be a lot less use of it. You know, it's just like in political scandals. Follow the money trail. Figure out who's getting paid for this. Who's getting the money for those Western blots. There's your person who's going to always come down on the side of, yeah, you got a confirmatory Western blots, they call it. They don't even do them in England anymore.
No,
but
not since 1992.
It's totally, and ask a doctor how it works. The doctor who prescribes, who says, got to have a Western blot to confirm this ELISA positive thing. How does that work, doctor? Sir, what are they now measuring about me that's different from what they measured with the ELISA test? He wouldn't know. He's not got any idea. I'll bet you there's scarcely 50 physicians in this country that know what a Western blot really is. They know when to order it, and they know they get a kickback on it probably.
AZT causes diarrhea. AZT causes muscle wasting. It causes a whole host of complications.
AZT causes instant old age. How do you know which is the disease and which is the effect of the drug?
There were many patients who developed blood toxicities. There were many patients who experienced other symptoms of adverse reactions. Think of all the people who died from what we think was AIDS, were those people in fact killed by AZT?
Using drugs that are targeted against HIV has been a tragedy, worse than useless. AZT was a terrible drug, and many AIDS doctors will admit that quietly and privately these days. Nobody, in a caring profession like medicine, likes to admit that they may have killed a lot of their patients.
AZT is an antiretroviral drug that became the first drug approved for the treatment of AIDS and HIV infection in 1987. It was originally intended to treat cancer, but it failed to show efficacy and had unacceptably high side effect profiles. However, the unavailability at that time for alternatives to treat AIDS affected the risk-benefit ratio greatly.
The antiviral drugs are chemotherapies. They're all based on chemotherapies that have been developed 30 years ago, long before AIDS was known, to kill human cells. Chemotherapy is restricted to a few months in the hope the cancer dies before you die.
If you started taking any other chemotherapeutic agent for the rest of your life, it would be that agent probably that killed you. When you give chemotherapy to somebody with cancer, you give them a round of it for maybe 14 days or a few days. Hopefully you're not going to kill the patient, you're going to kill the cancer. The patient's going to survive. But you don't keep giving it to him until he dies, because he certainly will.
AZT not only terminates DNA synthesis of all sorts, but it also acts in other ways. It acts in the mitochondria to lead to the oxidation of the mitochondrial DNA in ways which were not suspected. I'm thinking of the work of Miyazawa and Ozawa. It destroys mitochondrial function, and the mitochondria may be the secret to the degenerative diseases.
Initially, it was administered in much higher doses than today, typically 300 to 400 milligrams every 4 hours, even during the night. Modern treatment regimens typically use much lower doses, and like other antiretroviral drugs, it is almost always combined with other drugs in what is often referred to as a cocktail or highly active antiretroviral therapy. It is combined with other drugs in order to prevent mutations of the HIV virus into an AZT-resistant form.
A 1,200 milligram dose of AZT originally handed out to patients like candy, and they were desperate to take it, in 88 and 89 and 98 resulted in countless unnecessary deaths. This is proven beyond a doubt by the largest and longest study ever conducted of the drug AZT amongst asymptomatic people, that is, people who have HIV antibody but do not have symptoms yet. That was the Concord trial. And if you actually look up the Lancet publication of that trial, you find that the trial is divided into two groups of people. They're all healthy, they're all HIV positive. The one group that gets a placebo, a dummy drug that does nothing, and the other group which gets the real thing without telling people. Follow them for 3 years. When you looked at the people who went on the drug right away, in that group of people, there were 169 deaths. In the group of people that waited until symptoms developed to take the drug, there were a scattering of deaths, 2 or 3. Now, I think that's pretty persuasive evidence that that drug is and was harmful.
I've shown that the original drug trials, the phase 2 studies, were blatantly fraudulent, proving nothing. And yet it was the basis for the approval of AZT not only in the United States, but 30 other countries.
During the 3 years that I participated in the early AZT clinical trials, I witnessed the most shocking, unethical, unscientific, and corrupt behavior by the clinicians conducting these studies. Whenever there was an adverse reaction, such as diarrhea, or weight loss, or night sweats, or vomiting, or fevers, or the development of an opportunistic infection, this information was supposed to have been recorded on an as-needed form. Often these things were not recorded.
Was it possible that drug companies knew that their trials were misleading, that people were getting hurt by drug trials that produced no positive results?
The original research for AZT said that it killed infected cells at a rate 1,000 times greater than healthy cells. But there are now 4 papers
after that original one, which is also a Gallo Bolognese paper, this one, that shows that, in fact, AZT is quite democratic. It kills all cells equally at the same rate. And in fact, that means it kills healthy cells at a rate 1,000 times greater than they said it did.
Glaxo welcomes inserts to the physicians and the physician's desk reference, warns the doctors not to confuse the toxic effects of AZT with AIDS itself. AZT causes numerous AIDS-defining diseases. For example, AZT causes dementia, which is AIDS-defining, destroys the bone marrow, requiring life-saving blood transfusions of people that use AZT. This information you get from Glaxo Wellcome itself, the manufacturer.
They tested AZT, it failed, but what they said was, now wait a second, we know it works because the logic is correct. We've proven the logic. We simply have to work harder, do more experiments, but we will not give up the logic. So medicine's proof is the excellence of its explanations. The fact that it fails in tests is considered irrelevant because we know the explanations are correct.
So far, there have been no drugs that are effective, that don't have major side effects, that are affordable. But throw more money at us, and one of these days, maybe we'll come up with the vaccine or the drug or something that will cure this. But we're not making any promises. Don't ask us to promise that in 5 years we've actually made a difference with our drugs, because we can't possibly promise that.
What if you were to take a very healthy individual who had no risk factors for depressing their immune system, but every day, 4 times a day, you gave them one of the most toxic chemotherapy drugs ever created, AZT? What would you imagine would be the state of that person's immune system and overall health within 2 years? And yet that's exactly what has been done to countless individuals who have tested positive for the HIV antibody.
I initially was diagnosed in '89 and tested at a 900 level T4 count and was prescribed at that time AZT, which I took for a month and a half. And of course subsequently became very, very ill from it. And I decided in the meantime that as I was taking AZT to find out more about the drug, and as I learned it was extremely toxic, and I decided then to stop taking it and immediately got better. So at that point I had already had an early experience with the medical system and HIV treatment that had scared me and made me realize that they probably didn't know as much as they told me they knew about treatment.
They'll be taking the medications and they're looking gaunt, their skin's turning funny colors, they're real anemic, they're weak, sometimes coming in with canes. They do a little research on their own. We don't tell them what to do. We're about self-empowerment, self-responsibility, taking charge of your own life and health. They begin doing that, they get off the medications, color starts coming back, they start putting on the weight, they start feeling better. But there's a lapse, they get afraid again, they start taking the medications, we watch them start shrinking up again, they start looking gaunt, they start getting pale again, they start getting weak. Then they go, oh, maybe I should be doing this. They get off, they start coming back again. You actually watch this, and it's coordinated with taking these medications. It's just unmistakable.
To suggest that these drugs can be basically blamed for the symptoms of AIDS is lunacy. Because these drugs, as I mentioned, only came along around 1987, 88, and lots of people died of AIDS before then. So you're going to have to explain, if you posit that antiretroviral drugs are the sole cause of AIDS itself, then you're going to have to explain how all the people who died, gross, disfiguring deaths before those drugs came along, what made them die.
AIDS in the 1980s was primarily the result of the recreational drug epidemic in the US and in Europe. However, it shifted considerably in the 1990s. In the 1990s, at least half of all new AIDS cases, maybe even 60% now, are a direct result of the antiretroviral therapies themselves.
While the release of AZT in 1987 was not a cause of the 30 to 70 conditions considered to be the result of HIV infection, AZT certainly helped to hasten the deaths of countless individuals who were given the drug. And based upon my own research conducted within the fast-track gay community in New York City during the late 1970s and early 80s, there is no doubt in my mind that prior to the release of AZT in 1987, the development of the phenomena later identified as AIDS and the deaths of those individuals suffering from it were brought on in no small measure due to the hazardous lifestyles that they were living.
Protease inhibitors are medications that are very toxic. However, protease inhibitors have few good actions. They are antibiotic. So if the patient has an infection, it's going to work in the infection. They are anti-parasite. If the patient has a parasite, it's going to be good for it. If the patient has a fungal disease is going to work also as an antimycotic. But besides that, the protease inhibitors are antioxidant. So at the beginning or for a while, the protease inhibitors are going to do good. However, in the long run, when we give to a patient protease inhibitors, we are blocking the metabolism or proteins all over the body. So in the long run, the patient is going to die. And this is why nowadays the HIV/AIDS establishment is still repeating, there is no cure for AIDS, there is no cure for AIDS, there is not a single cure for AIDS.
AIDS has continued to increase with antiviral drugs of the DNA chain terminator variety and has decreased when recreational drug use decreased and continued to decrease when the protease inhibitors were introduced in '97 because recreational drug use continued to decrease. But it didn't decrease as fast because people who are HIV positive are now being intoxicated, rendered AIDS patients by anti-HIV drugs.
The biggest reason for people who are HIV positive to die nowadays is liver failure. Liver failure is not an AIDS-defining condition. Liver failure is, however, a common side effect of AIDS drugs.
You have a self-fulfilling prophecy. The more people are treated against AIDS, the more people will eventually develop AIDS from it. And then the perfect excuse is delivered with the medication. You can say, Jesus, if I hadn't medicated you, you would have been sick even sooner and would have died sooner. But thanks to my medication, you are only getting sick now, and we're giving you even more medication. We need more money to develop further medications that have yet to cure the first AIDS patients.
Since the mid-1980s, on a regular basis, the headlines have touted amazing new promising drugs in the war on AIDS, the antiretroviral drugs. The trouble is, when you look back honestly, they didn't work, and tens of thousands of lives have been lost. Very few lives saved. These were not miracle breakthroughs that we were promised.
The miraculous protease inhibitor cocktails are a direct result of David Ho's work that he published in the scientific journal called Nature back in 1995. That paper in 1995 was the principal justification that the FDA used to release the protease inhibitors next year in 1996 for general use among the American public.
Dr. David Ho, named Time Magazine's Man of the Year in 1996, was first to propose the dynamic nature of HIV replication in infected persons. According to Dr. Ho, when antiviral drugs were administered to an AIDS patient, replication of any new HIV would cease, and viral loads would decrease accordingly. However, the reality was, in a few days of administering these drugs, the remaining virus would mutate into a form resistant to drugs, and after several weeks, the viral load would return to its pre-treatment levels. This paper was largely responsible for the advent of combination antiretroviral therapy, including the use of protease inhibitors.
In 1998, a group of researchers at University of California at Berkeley and the University of California at San Francisco joined forces to test David Ho's viral dynamics hypothesis. And in short, their results are that Ho's hypothesis is wrong. HAART actually does what HIV is supposed to be doing. It produces a shorter lifetime for the T cells in HIV-positive people taking the drugs as compared with HIV people who do not take the drugs.
And he came up with a completely new model of the virus, saying now we have not a slow virus, but we have a virus à grande vitesse, at high speed. And he was using Kary-Mullis' PCR technique, which is a multiplication technique, not a quantification technique, by the way. Even more, as those sequences he's going to multiply and equal them with the virus, that's the viral load, are present in everybody. And a new test where the pharmaceutical companies could make a great business out of it.
Invented by the AIDS dissident, Dr. Kary-Mullis, PCR, the polymerase chain reaction, is a technique that enables a scientist to take a sample containing a minute amount of DNA and replicate that DNA sequence until there are 1 million copies. One of PCR's first applications was to try to detect HIV. According to Dr. Mullis, PCR amplifies whatever DNA is in a sample, regardless of whether that DNA belongs to HIV or a contaminant, and that there is no sure way to determine which part of the amplified material could be HIV and which part could be a contaminant. According to Dr. David Ho, viral load was measured when antiviral drugs were administered to a patient. These drugs were supposed to prevent replication of any new HIV, and viral load would decrease accordingly.
The pictures of HIV